So moving on to HRT and estrogen, because still talking about incontinence, there's someone here wants information on the use of topical estrogen to help with stress incontinence.
Yeah, absolutely. So the evidence, again, shows that topical estrogen, well, let's talk about what estrogen does for continence, first of all.
Yes.
It's going to really, it plumps up the tissues around the openings in the perineum. So if we're thinking about the perineum, we've got 3 openings in the female perineum. We have the urethra, which is coming down from the bladder, the vagina, and then the anus. And if you have low estrogen, those openings, instead of being nice and plump and staying closed by themselves, and the muscles supporting everything on the inside and the ligaments keeping the organs where they're supposed to be, the tissue can get a little bit thinner and less responsive. So your 2 main plans are going to be either topical estrogen or pelvic floor physio. But the evidence actually shows if you put those 2 strategies together, you get better results than either by themselves. So to go talk to your GP or your gynae and get the topical estrogen cream. And what's nice is there's very minimal systemic absorption of topical estrogen when it's applied around the vulva. So it's going to act locally, and then you work with your pelvic floor physio to get a good strategy, and then maybe with an appropriately qualified fitness professional, because we want movement to be a lifelong strategy, you know, that's really going to carry you through. So you want to use the topical estrogen almost as a boat to get you to the other side and to give you a little bit of a head start, a little bit of a kick to get you going. And then your pelvic floor rehab strategies and your global all over body rehab strategies are going to be what's going to keep you out of trouble.
Great. And how about estrogen with lichen sclerosis, topical estrogen, HRT, does that help?
So topical estrogen would not be the first port of call for lichen sclerosis. You'd be looking at, you know, talking to your gynae and doing something like clobetasol, you know, to get the lichens under control first. Some women do use some topical estrogen with that as well. Oftentimes, a lot of the pain from lichens can come from either the labia becoming quite bound down with the lichens, but also some pelvic floor muscle overactivity as well. So that's another situation where you want to get that combination of a pharmaceutical topical, either the clobetasol or topical estrogen at an appropriate time, but in combination with pelvic floor rehab, because there's a lot that we can do in terms of just showing you how to do some soft tissue work on the labia, maybe using dilators to keep the vaginal introitus patent as well. So again, multidisciplinary care for women's health, particularly for pelvic health, really is the way of the future. I think it's not, you know, we don't have to be none of us have to be a one-stop shop for women, and it's about teamwork.
Yeah, absolutely. How about HRT for pudendal neuralgia?
No.
No.
So pudendal neuralgia is just one of the most misunderstood diagnoses out there. The pudendal nerve supplies most of the motor and sensory function in the pelvis, in both men and women. And all pudendal neuralgia means as a diagnosis that there's pain somewhere along the course of the pudendal nerve. There are lots of other nerves in the pelvis as well. You know, you've got your posterior femoral cutaneous nerve, but basically, let me just grab a pelvis here. The pudendal nerve really only supplies this very narrow area here, just over the perineum. So what you want, if you have pudendal neuralgia, is you want to go to somebody who's going to be able to assess you, lumbar spine, hip, pelvic floor, internal and external, and find out what is actually driving the problem with your pain in the pelvis. Is it a muscular problem? Is it an actual physical entrapment problem, maybe after a surgical procedure? So there's a lot that we can do in terms of mobilizing soft tissue, re-establishing movement, using pain neuroscience education. Constipation is another big driver with pudendal neuralgia as well. Lifestyle education is a big part of it. Do hormones play a part in this? Well, we know estrogen, can affect pain perception, but it would be way down the list of things to try for pudendal neuralgia. The main thing with the pudendal nerve is to find out what's making it unhappy, and then to calm it down, and then to build up some resilience in the tissues around it.
Okay. All right. And you talked about, someone's asked, is it safe to take HRT pessaries? And I think you're generally saying yes, aren't you?
Yeah, I mean, hormonal therapy has come on an awful lot over the past decade. And generally it has, there was a study that came out last year, and there was a big kerfuffle because the headlines in the newspaper and the media were quite misleading about how HRT is now associated with breast cancer. It's far less likely to cause breast cancer than having a glass of wine every night. Alcohol has a much stronger association with breast cancer. Being overweight has a much stronger association with breast cancer. Having said that, hormone therapy, again, is a boat to get you to the other side. It is not an excuse for not cleaning up your lifestyle in the areas that need cleaning up.
Yeah.
And if it is a local problem in terms of pelvic health, whether that's sexual dysfunction, if you're not producing enough lubrication, if you're having some leakage, then it's in combination with a pelvic rehab strategy. Have you tried good lube? Are you using a vaginal moisturizer? I would try all those things first, because there's minimal systemic absorption of topical estrogen, but there is some. Once you take a medication orally, it has to go through your digestive system and be broken down by the liver and processed and goes through the whole body. So I would look at all of the different aspects and then make an informed decision about what's right for you. But if you're not eating well and exercising well and managing your stress well and prioritizing good sleep, you have some work to do.
Yeah, it's those lifestyle factors again.
It really is. But I'm not anti-hormone therapy by any stretch of the imagination, because there are some women who are so distressed by the night sweats and the hot flashes, they're not able to live their lives. But again, it's a short-term measure to get you out of trouble, and then you use lifestyle to keep yourself out of trouble.
Okay. Any thoughts on HRT in perimenopause?
It depends when you're going through. Like, if you're going through a very early perimenopause, there could be a case to be made for its protective effects on the bones and for the heart. But again, what else is going on? Generally, what we see is that hormone therapy in women who are going through your standard issue menopause, if you like, they want to take the lowest effective dose for the shortest period of time. The longer you take hormone therapy, the less beneficial it is for you. So it's okay for that short transitional period going through, but honestly, it really is about getting your ducks in a row before menopause hits. The better shape you are going into menopause, the easier your journey is going to be through it and after it.
Right. Okay. There's a question that's come in live. Lichen sclerosis seems to appear most commonly at menopause. Why is this? Is that true?
I don't know that that's entirely my experience. I've seen a lot of women pre-menopausally who have it, as well as peri and post. Is there a hormonal driver? Yeah, probably. I'm sure it has a role to play in there as well. But, that's really, it's a situation where you want somebody who's really specialized in vulvar dermatology, because there are lots of different dermatological issues. And my fear is sometimes that accurate diagnosis is not always delivered. Is it lichen sclerosis? Is it lichens planus? Is it BV? Have we got early stage genital warts? Really, really important that if you suspect that you have lichen sclerosis, that you get an accurate diagnosis, and then take it from there. But generally, it can be well managed, again, with that combination approach of pharmaceutical and pelvic rehab.
Right. moving on to vulvodynia and pelvic pain, vulval pain. So is there a connection between menopause and pain?
Yeah, so I think if our estrogen levels are lower, there are some sources saying that we're more likely to experience pain. You know how they say you should never go to the dentist the first, day one of your period, because, your estrogen levels are just that little bit lower and you might experience more pain. The tissues are a little thinner, and a little bit more delicate and can be a little bit more irritable. We have to look at big picture issues with vulvodynia. I think sometimes we get very focused on the vulva in vulvodynia, and we have to be able to look at what else is going on. Has there been a change that's affecting the mucosal lining? I think for a lot of women, they find that they become less tolerant of certain foods, certain washing detergents, certain chemicals as well. So the tissues definitely have a change sensitivity. Is there increased tone in the pelvic floor muscles because of other stressors that are going on? Vulvar pain and vulvodynia in general, it's such a broad diagnosis. We can talk about, provoked vestibulodynia and try and narrow it down a little bit. But if we're talking about vulvar pain in general, is it because of the lack of lubrication and maybe some micro trauma in around the tissues inside the vestibule? Maybe wearing tight jeans, maybe, as I said, like a change in laundry detergent or going to a swimming pool that you haven't been to before. The local tissues have some micro trauma. The pelvic floor muscles go into protective mode in response to that from the brain. And then we just start to see this spiral. So to be a good clinician working with women with vulvodynia, you really need to do some detective work and find out, is it provoked? Is it spontaneous? What else is going on? What are her stress levels like? When did this start? What do you think is causing this? Definitely we need to look at the mucosal tissues, but 90% of women with vulvar pain, with vulvodynia, will have overactivity in their pelvic floor muscles again. And oftentimes that initial trauma, I'm just, how there's always that one person that springs to mind when you have these conversations. I'm thinking of one woman that I was working with who had decreased lubrication. She was still trying to have penetrative intercourse with her husband, but she was developing micro trauma in around the posterior fourchette of the entrance to the vagina that we couldn't see with the naked eye, but when I got my magnifying glass out, we were able to see the little micro tears in there. So of course, when she emptied her bladder, it was getting irritated. She tried putting on some topicals to calm things down. She tried using a well-known brand lubricant that had a lot of glycol in it that irritated the tissues even further. And the whole thing just kept rolling and rolling and rolling. Pelvic floor muscles then started anticipating pain with intercourse. She couldn't wear jeans. I mean, you've heard the story, I'm sure, many times. And so what we had to do was start just peeling the layers off, calming things down, and then building things up, to paraphrase my colleague Greg Lehman. So it is about hearing the story, when it started, and then being able to pull together all of those maybe seemingly disparate pieces together. Is it menopause? Maybe because she had some decreased lubrication issues going on. That might have been one of the triggers for it, but it quickly gathered steam in a lot of other areas in her life. And it is very much looking at the whole person and the whole story to solve these issues. So I'm disinclined to blame menopause for vulvodynia, because I think there are so many different drivers that are possible out there. And I think too many things have been blamed on menopause in the past.
Yeah. And because it's never ever just one thing, is it? It just can't be. We're just more complex than that. Someone's asked the question the other way. In your experience, has the menopause helped with vulvodynia?
For some women, they start, their pelvic pain does start to diminish, for whatever reason. Maybe they're just more relaxed. Maybe they're not worried about getting pregnant anymore. You know, maybe they're moving into a phase of their life where they have more financial freedom, they have more job security, the kids have finally left home, you know, things are calming down in their life. Vulvodynia it's almost like a mirror of what else is going on, I think, to a degree in your life as well. And the rest of your life will either turn the volume up or potentially turn the volume down as well. And I think, you know, I've had a conversation with Sandy Hilton, and Beth Darnell writes about this very eloquently in her book as well. It is about seeking out pleasure in all different aspects of your life, making sure that you're having regular pleasure hunts in your life when you're dealing with any sort of chronic pain. And I think sometimes for women, menopause is painted as doom and gloom and terrible and awful. But for a lot of women, it is actually a bit of a wake-up call, because we realize it's not a dress rehearsal. We're probably halfway through. Let's start enjoying our life maybe a little bit more. You know, maybe that we have now this freedom and space that we can invite more pleasure into our lives. And I think that that's definitely got to play some sort of role in decreasing any chronic pain condition.
It's looking at all those factors again, isn't it?
Always. Zoom out.
Right, we've got a question here. I've suffered with vulvodynia off and on through the years. I currently have vaginal dryness with tears and very sore perineum. My gynecologist has recommended PRP therapy, platelet-rich plasma therapy. The cost is $6,000. I hate needles and having blood drawn in the first place, but this just sounds awful. Any thoughts?
Well, yes, one or two. Have you tried everything else first? Because oftentimes, and I'm going to make a sweeping generalization here, it has been my experience that sometimes some of my medical colleagues go to a conference or a training and there's a bright new shiny thing and they get super excited and maybe overlook a couple of steps before we try the big new shiny thing. So I would be inclined personally to just take a step back. Have you tried vulva and vagina friendly lubricants, moisturizers, specifically for the vagina and the vulva? Have you tried pelvic rehab? Have you seen a pelvic floor physio who's experienced with menopause and with pelvic pain and with sexual health? How are your pelvic floor muscles? Have you tried topical estrogen? Is it a problem, possibly, of sexual ergonomics? Maybe it's the position that you're in as well. So have you talked to somebody who can, and again, a good pelvic floor physio should be able to guide you through this. It could just be a positional change that's required. Are you using the lubricant properly? Would be another thing, and as well as using the right type of lubricant. PRP it's quite cutting edge. I don't know that there's a huge body of evidence to support it for this specifically. So I would be more inclined to try the less invasive, less aggressive, less expensive strategies first.
Yes, good advice. Okay, on to vaginal atrophy. What can one do to reduce it, if any, when they're perimenopausal, or to keep the vulval skin from atrophy with vulvodynia to be able to keep comfortable and active? Absolutely.
Apart from the things that we've talked about, you know, the topical estrogen combined with pelvic rehab, there's some good research out there showing that doing your pelvic floor exercises properly, she said with great emphasis, can actually improve tissue condition, but also lubrication. So we've some interesting research that came out last year. It was a small study, but we did see about a 30% increase in lubrication with doing pelvic floor muscle exercises over a 12-week period, which I thought was quite interesting. If tissues are atrophying, if they're becoming quite dry and maybe not as plump and as healthy as they used to be, what do we want to do? We want to make sure that we're bringing good circulation to the area. So orgasm is a great way to do that, either by yourself or with a partner. Doing some soft tissue mobilization, again, with a nice vagina-friendly lubricant can be really good. So if we think about, you know, our vulva, and we're just massaging the tissues very gently in and around the labia, bringing a little bit of, I mean, if you do your forearm, if you just press your forearm and release it, you'll see how it goes white and then it goes pink again as we get a little bit of capillary refill. So doing some gentle self-exploration and self-massage in a non-sexual way even can really help bring some circulation and some elasticity to the tissues. Generally, again, a combination of topical estrogen, of pelvic rehab, and of specific pelvic floor exercise, really important to that. You want to stay away from anything that's going to irritate the tissue. So cotton underwear, avoiding jeans that have a very tight seam in the crotch. Fresh air is fantastic for vaginal and vulvar health. So, you know, let those tissues breathe, but get them moving and make them happy, because the female orgasm essentially is a series of rhythmic contractions of the pelvic floor muscles 0.7 of a second apart. So it's a great way to bring blood flow into and then out of the area again. So you're literally building resilience from the inside out. And then by doing a little bit of soft tissue mobilization yourself to the labia on the outside, on the inner thighs, sometimes, I'm just trying to see if I have my little demo one here, using something like a vibrator, but using it externally on the tissues around the labia. So just even, you know, very low frequency, nice and gentle, again, just massaging those tissues can be a really nice way to bring a little bit of health and wellness back into that often neglected part of the female pelvis. It's not just about what's going on inside the vagina. You have to look at vulvar health as well. And the other area that often gets neglected is the hood of the clitoris. So when our estrogen levels are low, sometimes the hood of the clitoris can't retract properly and it can get banged down a little bit there. We call that clitoral phimosis. So just being able to very gently move the tissues around the hood of the clitoris back. Again, a little bit of topical estrogen can be quite useful for this, but you can use a lube or a moisturizer. Just one quick word of caution about lubes and moisturizers. If it's a new to you one, always do a patch test on your forearm first, 24 hours ahead of time, before you put it anywhere near your vulva, because I would much rather you have a reaction up here than down there. So just do check, because different people have different sensitivities to those compounds. But bring some attention to the area, exercise it, either orgasm, but just even going for a walk is a great way to make sure that you're moving the circulation, both lymphatic as well as vascular, through that area. And again, avoiding constipation is really important, because if you have that kind of stagnation in around the center of your body, if your bowels aren't moving properly, that is really going to impede circulation in around the pelvis.
And I think from when you talked about the lifestyle factors and looking after all of those, it's answered quite a few of these questions. You know, any advice for women who suffer daily symptoms caused by vaginal atrophy? Again, it's looking at those lifestyle factors, going through them one by one. We've got an interesting one coming here. How can we help single women who've never had a sexual experience to have healthy menopause?
So this is where knowledge is power. And there's some really great books out there. And I can certainly send you a list of recommended reading material. But one of my favorite books about female sexual health is a book called Come As You Are by Emily Nagoski. And it's a great book at explaining, you know, really, to paraphrase Nika Goldberg, that women are not small men, that we have different sexual response cycles, that we have different stimulants and different phases of our sexual lives. So that's a book that I would strongly recommend having a look at. Self-exploration is fantastic. Christian Northrup writes about this a lot in her books. You don't need a partner for a satisfying sex life. In fact, Christian Northrup, in one of her books about menopause, wrote that the best predictor of good sexual function at midlife is a new sexual partner, but you can be your new sexual partner yourself. You know, there are great tools, obviously, for self-exploration, you know, hand mirror, vibrators, but just exploring yourself and finding out what you like. Is it watching Outlander? I mean, who doesn't love Jamie Fraser, you know? But finding out what works for you, what gets you excited and happy. There's going to be a video on my YouTube channel in about 2 weeks with 2 sexual health experts, and it's about the pleasure prescription for women, particularly women with vulvar pain, and how pleasure is really a fundamental, it's not an optional extra. You know, it really, you know, sexual health particularly, it's in Maslow's hierarchy of needs. It's one of our basic needs as a human being. And I think sometimes as women, we've been conditioned to think that we can't be sexual beings if we don't have a partner. And I think maybe it starts as being a sensual being, you know, and really just starting to get back into your body again and finding out what you enjoy as a woman. But the Emily Nagoski book certainly will be a great place to start.
Yeah, great book, and absolutely a little bit of self-exploration. Yeah.